Hi, and welcome to the PT Revenue Resource by Medical Billing Center. My name is Brianna Hall. I am the Director of Development for Medical Billing Center. And today we are talking to Jim Stoker, PT, DPT, who is the CEO of Medical Billing Center. And our topic for today is KPIs and monthly review standards when physical therapists are going over their billing review. So we're going to hear all about how MBC treats a standard billing review and what kind of things you can ask for in your clinic going forward.
Well, thanks, Brianna. So I was thinking earlier about how it would be beneficial for people to know kind of how NBC approaches the relationship. And I believe that's what makes NBC a little bit different in the fact that we were founded by physical therapists. We are still run by physical therapists. And we view ourselves as a billing partner, a full service billing partner. And as part of that is I treat it just like I did my practice. Any owner should have at least a monthly billing review. So where do you stand in regards to standard KPIs? I thought it'd be helpful to share some of that information. So a standard monthly review, things that practice owners should be looking at, starts with the basic aged AR. So your AR with insurance and patient in 30-day buckets. Where do those buckets stand? Kind of an industry standard for a long period of time, you look at 90 days and above as a percentage of your total AR is 15% or less. That's kind of where you start. You're like, all right, are we where we should be? Now, we have plenty of clients that are below 15%, and the goal doesn't stop at 15%. Some of our best practices are below 10%, but it's a starting point. But if something is out of line, which does happen, billing and collections is an imperfect function. Something is always going haywire. That's what we do, is we watch for those things. We identify them. So when we identify a particular bucket, a percentage is out of line with the total, the next step is actually drill down to what I call a carrier report or a payer report. So it's the same aged AR by payer or carrier. And so that then allows us to drill down even further, say, okay, is it one payer? Is it multiple payers? And remember, patient is a payer. Mm-hmm. So I'll give you an example. When we look at the total aged AR bucket and we look at patient as a percentage, the patient portion of each AR 30-day bucket should be less than 10%. If your total is more than 10% or any one 30-day bucket is 10% or more, you absolutely have an opportunity. I just had a review probably 2 or 3 weeks ago with one of our best performing clients. Their patient percentage of each AR bucket was 5%, and they had a couple buckets that were less than 5%.
Amazing.
Folks, it can be done, and it's extremely important. You have to view the patients as one of your more important payers, just like Blue Cross Blue Shield, just like Medicare, just like work comp. All right. Mm-hmm. So we look at the overall AR. If we see an issue, we drill that down to the carrier report. Then we say, all right, there's one or two carriers that's causing that. Then we can drill down that carrier. It's like, is it one or two patients? So you start big picture and you gradually drill down to the issue. Is it an issue that's across the board with that particular payer? Is it one or two patients within that payer? And you drill down to the specific issue. So we've also recently implemented an AR platform called RCI, which provides a lot of that visibility into the platform and into Worklist. So we're not relying on individuals to do that manually. So it's speeding up the process of identifying what the payer issue is in that particular bucket. All right.
So let me slow you down just a little bit here. And so if you're talking to a PT who owns a practice, or maybe it's even a PT who doesn't own a practice yet but wants to own a practice,
Mhm.
what would you tell that physical therapist the most important billing KPIs are to keep an eye on? So aged AR by bucket and aged
Mhm.
AR by payer is kind of what we've gotten so far.
Right. Right. DSO stands for Days Sales Outstanding. That's a measure of basically how fast you're getting paid. Generally, when you measure DSO or even your aged AR, it is a standard to carve out attorney accounts. That varies greatly between clients because attorney accounts can be 2 or 3 years.
Mhm.
Whether you and your practice decide to take letters of protection, whether you accept attorney accounts, whether you require them to bill their own private insurance, and themselves, that's your own decision. But it is a standard to kind of pull the attorney counts out of it because we know it's skewing all the numbers. So DSO 30 days or less. Again, our best performing practices are in the high teens, 17,
Mhm.
18. Payer mix affects that greatly. If you have a practice that is 50% Medicare and 30 to 40% Blue Cross Blue Shield, your standard DSO expectation is going to be lower than if you have 20% Medicare, 10% Blue Cross Blue Shield, and 50% work comp or
Mhm.
other commercial. ASH, that goes through a third party administrator, ASH, those just take time to review. But DSO standard review. Historically, people looked at clean first pass clean claims rate. And it is still something we look at. First pass clean claims rate is a measure of how many claims hit the clearinghouse the very first time. If they don't hit the clearinghouse first time, it's called an exclusion. The most common issue for an exclusion is a coordination of benefits issue. Misspell the name, the address doesn't match exactly, what have you. It's usually a demographic typo type thing, or maybe it's a benefit. Maybe they didn't tell you they updated their insurance and they've got a different insurance than they did last time. Something like that. Um, Generally, the industry standard for first pass clean claim rate has been 95%. We have seen, and we now expect that number to be higher because of the new platforms that are available,
One of our
and the
best
reviews
performing
that can
clinics, I
occur
believe.
prior to clinics going off. So our best performing clinics are 98%.
Mhm.
And that leads me to our next KPI, which is actually now denial rate. So we're actually starting to look at denial rate more than clean claim rate. Denial rate actually is beyond the carrier, actually to the payer. So denial rate, we're seeing best practices 98%. Denial rate would be 2%. Acceptance rates would be 98%, depending on how you want to phrase that. But 2% or less is I think is a standard and a goal, and it's very achievable.
Great. So what I have right now for our listeners is aged AR by bucket and payer, DSO, payer mix, first pass clean claim rate,
Mm-hmm.
98% is a goal, and then denial rate 2% as an achievable goal.
Right. And I think that's the core of your true billing and collection metrics and data points that you want to look at. It serves as the basis for a standard monthly review. And as you get in a sequence of reviewing this, what you're looking for are outliers. All right. Everything's looking good. Hey, that's great. We're plugging right along with outliers. Then if you're in a habit of looking at these things, all of a sudden now outliers stick out like a sore thumb. And you can address them more quickly. So there's other metrics that we follow that we enjoy reviewing with clients, and I think that practice owners should review consistently. Probably some they're more familiar with that are billing and collections, but they're also operational metrics. So We enjoy that part, and we engage our clients beyond just the straight billing and collections. We enjoy talking about how billing and collections impacts operations. So, for example, we have a standard monthly report that clients can receive that reviews that month's charges, payments, adjustments, contractual adjustments. It does have DSO on that report. It has payment per visit. I also look at payment per unit because obviously your units per visit impact your payment per visit. And because our systems are able to extract contractual adjustments, we can derive a true net collection percentage. So charges minus contractual adjustments equals what you should be paid. And then if you take what you should be paid, what you're paid divided by what you should be paid, you have a true net collections. And so we follow that monthly, and we also like to see a trailing 12-month view because there are cycles. That's why I call it revenue cycle management. There are cycles to that, and seasonalities just like there are with seasonal volumes in physical therapy.
How does Medical Billing Center do a monthly client review? What does it look like? What do we believe our best clinic practices, our partnerships are looking for, and how do we support them?
Mm-hmm. Well, first of all, we customize it to the client. Generally, when we have a new client come on, we'll have at least a monthly review. Sometimes actually more frequently than that for the first couple months, probably every week to 2 weeks. We've engaged, making sure everything's working all right. We're kind of getting them used to the systems and just reviewing procedures at the front office, make sure everything's flowing smoothly. As we work to the monthly review, we have a set standard time. It's generally at least a week after the month closes, somewhere anytime within the month to review the previous month. That's where we review our trailing 12-month chart to see charges, payments, adjustments. We identify trends that are up or down. We identify positive trends, and we enjoy congratulating our partners on growth and doing well. And we see anything that's a negative trend. And then we can drill down from there to what is there an issue? Is there something we can help coach them? Is it something that MBC can identify and improve? Is it something we can coach the owner that they can improve at the front office or their clinical staff? So that's kind of how we structure it. We have plenty of clients that we have met with on a monthly basis. And they're like, well, everything's just kind of plugging right along. So we've defaulted to a quarterly review. And so, but again, the most important thing for me we like to customize it per the client's needs.
Mm-hmm. That's right. And then if you were coaching a clinic practice owner who, let's give two different scenarios. I'm going to give you a practice owner who is looking at this stuff every month, is on it, is asking their staff about it, or asking their billing company about it, whether it be us or, another billing company. What do you think they're doing right? What do you think they could ask for? What do you think, how would you coach that owner? And then let's also talk about, on the flip side, an owner that isn't looking at any of these metrics right now and is just kind of surviving.
Right. So the owner and it's a fairly common challenge, is you have an owner, one clinic, maybe two, growing the owner. And I've talked about this before on our conversations, is that the owner feels and believes they have to see every single patient. They have to see the most patients, and they are sacrificing managing and their attention to the business. So that's a pretty common scenario. When we engage those owners, we actually put some math to the numbers. So I explained to them that if you coached your team, if you took an hour a week and coached your team, and if you improved your unit per visit or your payment per visit or your charge diversity by X, that turns into Y amount of revenue per month, per quarter, per year. And so we actually like to demonstrate that value. And so those owners that are finding a hard time um, managing the schedule and allocating time to work on the business, we want to engage them and talk to them about the benefits and help them understand how and see the bigger picture for the practice. The clients that are looking at it already, sometimes you get a little focused on one particular metric. And again, I always like to coach people: start big picture, identify the outliers, drill down to the challenge, fix the challenge. And you restart that view every single time. Go through the same process. Think about it just like evaluating a patient. In my career, I lost count of how many rotator cuff tears or surgeries that I saw. It would have been a mistake for me to make an assumption about this particular patient because I've seen a grade 2 rotator cuff repair 1,000 times. Go through the same process, start big picture, start with the history, and then gradually drill down to the challenges. And that's exactly how we approach the monthly review and for each client.
How would you describe the difference between a billing vendor and a billing partner?
That's a great question. So a billing vendor, I believe, is the company that plugs in, that they pull all your visits, notes, charges, send them out, collect the money, send you the money, and maybe send you a couple of reports. Many of them don't send you reports. You have to generate the reports. They'll teach you how to do your own dashboards, and then you kind of hunt and peck and look at your own reports. That I consider more of the vendor type, and that may fit some people's needs. We view the partner as full service. So we actually serve as the patient contact, which many of the vendors don't. So when you partner with MBC, you have a billing number, and when a patient arrives at the front desk, or they call your office and say, "Hey, I have a question about my EOB. I have a question about my statement." They're like, "Oh, call our billing department here," and we give them the number. The phone rings here at MBC, and we actually talk to the patient. We'll take payments for the patient. We'll post those payments to the patient. So a lot of what we do is engaging and interacting with patients. That's a pretty big deal. That's a lot of interaction, a lot of phone calls, a lot of time and effort that we can unweight the front desk. So your front desk can focus on maximizing the schedule. You can collect your copays with the people right there in front of them. That's a large part of, I believe, what the vendor is, and then what the partner portion of what we do is. The other is exactly what we've talked about. We want to review with you not only complete the task of billing, collections, and payment, but engage you about the process, engage you about how it's going, and talk about opportunities for improvement, trends, teach, coach. One thing about coaching is we'll do physical therapy compliant billing presentations for staff. We'll do lunch and learns, do webinars. So it's an educational opportunity. And again, that's what I truly view as a partner relationship.
Yeah, absolutely. And it's one of those things that we saw. So you and I were in Georgia last weekend for the APTA annual conference, and you spoke at the conference, which I would love to kind of share a little bit about how that went. But I think what we saw when we were there, specifically during your talk, was that practice owners that we were engaging with, they really need that coaching and that help. We kind of had this back and forth about vanilla billing, right? And some practice owners being really nervous about charge diversity, feeling so much more comfortable just billing the same codes all the time. So let's talk a little bit about that, and I think just kind of share some of your insights from that trip.
Right. So part of that conversation, we started talking about, remember your billing record that you send to the insurance payer, the carrier. That's what they see. All right. Your numbers to them. Like it or don't like it, your numbers. They have actuarials that they do nothing but determine this practice and physical therapy as a whole in this particular region of the state or of the country. They bill X percentage, X percent of 110, X percent of 140. That's your profile. All right. If you look at the definition of 97110, basic strength range of motion. All right. It's isolated strength. If we're talking about the same rotator cuff patient. They're in the acute phase. You're doing manual passive range of motion. You're doing pain modulation. You're trying to calm down some muscular guarding. So you do some manual techniques like that. So it's typical. You're going to bill 110 and 140, basic thorax and manual. As that person progresses, the way I describe it, you should see your charge diversity develop just as you should see your flow sheet develop. So as soon as you move to multi-joint activities that are remotely functional, and every PT does functional stuff, you should move away from 110 to 530. 530 typically has a higher payment. Most importantly, it's best for the patient, and it's accurate depiction of what you have done for the patient. So the insurance company, if you now have an accurate representation of your skill set and of your program development with that particular patient, as demonstrated by your CPT codes that you've sent the insurance company. All right. So you should see less and less occur with 110, 140 as the patient improves, gets better. Is going to progress through 530, 112 neuromuscular. And those are the four primary codes, understanding there's a few other codes that you can do, but that's the general progression that you like to see. And it also depicts that the physical therapist is functioning at the highest level of your license.
I think that we hear all the time, we'll get people calling us and saying, "Hey, can you help me negotiate my contract? I'm not getting reimbursed." And if I had a call yesterday with a guy who was like, "I need somebody to tell me exactly how much each one of these codes reimburses at and which codes I should be using and not using and all this stuff." And I was like, "Okay, slow down. I understand." So I think that it's a full picture, right? It's not just any one, there's no magic bullet that's going to, get you better reimbursement. But when you do all of these best practices kind of in conjunction with one another, that's where we see a lot of success and opportunity for PT clinics.
Right. Very true. So there are a lot of resources to support private practice to engage in insurance contract negotiation. My personal beliefs, I'm a big believer in APTA, membership benefits. My state association, my national association, also I've been a member of the Private Practice Association as long as I can remember. Between all of those organizations, there are a tremendous number of resources available to practice owners to learn how to engage in contract negotiations. The first step is you got to find somebody, and you have to be persistent. It is not going to happen quick. It's not going to happen fast, but you have to commit to the process, and you have to find an individual. And once you find that individual, you're going to develop a little bit of a relationship with them. You're going to talk to them. They get to know you as a person. Then they get to know you as your practice, your demographics. Then you finally get to the point where the data matters. That's where you get to, we provide high level care. We have appropriate charge diversity. We walk people through their education. You're going to be persistent. It may change. Once you find that person, you need to engage that person. You have a little bit of a relationship. Allow them to get to know you as a person, as a PT. Then they can get to know your practice.
Now,
then you can get to.
Can I ask, when you say find a person, break that down for me?
I'm sorry. Yeah. So find a representative at the carrier that you're most interested in negotiating with. So is it Blue Cross Blue Shield? You need to find a Blue Cross Blue Shield rep. We used to have payer reps that they were assigned to you. Well, insurances don't do that anymore. You can still, with some persistence, find a payer rep for most carriers, but it does take persistence.
I'm going to write that down as a source for us to be able to kind of like maybe a guide or a resource on that.
Right. So once you get to know that person, they get to know you, then you can drill down to the data. And I've made that mistake a little bit. Is I'm so anxious and I'm so passionate about our practice and the fact that we take great care of good people, and we deserve an increase. We hadn't had an increase from Blue Cross Blue Shield in 18 years, and you finally get that person on the phone and you just dive right in. And they're like, "Whoa, I don't even know this person," and that's a little you've created a little bit more of an uphill battle. So understand you need to have a little bit of a softer introduction. You need to actually, again, get to know that person, find out their background, then introduce yourself. Then you can introduce your practice. You get to the history, then you can accomplish. I believe that's a more effective way to accomplish the goal.
And it's interesting because I hear a lot of the opposite. And when I'm getting people asking me about this, they're desperate, right? They're like, I need somebody to fight for me to renegotiate my contract. And that's it's interesting that maybe it is a personality trait, or maybe it's that you can't wait until you feel that kind of anxiousness to act or to join, the APTA,
Right.
or to find resources. You gotta be a little
Right.
proactive.
Step one is to locate and know your payer agreements. I would suggest a significant majority of PT practices, particularly small practices, don't have their payer agreements, don't know what their payer agreements are. That's step one. You need to know what it is, what it says, how much it says, when you became a provider, when it's effective, what are the terms. You need to have your agreement. So challenge number one: if you don't have those, you need to find them. You need to get them. In the process of finding those, you might actually find that payer rep you can have a conversation with. So you can actually kind of walk down those paths in parallel.
Yeah. All right. Well, let's wrap this up for today. Any last parting guidance that you have on monthly billing review standards, KPIs, renegotiations, understanding your payer mix, picking the right billing vendor?
Right. So allocate time. I think the number one thing that's most difficult for practice owners, particularly small practice owners, is to make time. It's one of those things that I need to get to it. I want to get to it. I know it's important, but I've got this patient. I've got to see this patient. And at some point in time, you have to understand that one patient, you will see patients. You will get them in the door. You need to delegate that, trust staff, teach staff, coach staff. But as the owner, you need to allocate and dedicate time to all these things that we're talking about. It will provide benefits for your practice down the road.
Yeah, absolutely. If you are not currently a partner of MBC and you are interested in learning more about what we do, or you're interested in having a discovery call with myself or Jim Stoker, you can find out more about Medical Billing Center by visiting www.4mbc.com. And you can also click the link that will be in the show notes. And thank you guys for your time today. And we are excited to continue to share more things each week about how practice owners can implement simple strategies to make their operations better, give themselves a little bit of a reprieve, and hopefully collect more revenue.
Yep. I always like to talk shop. That's the best part of the day, when I get to interact with the owners and talk shop and game plan and strategize.
And he's one that you guys definitely want to be talking to.